This patient was referred to me for root canal treatment on that mandibular second molar with the chief complaint of dull, radiating pain increased by bite. What's really going on here? What do we need to know about this scenario? And what conversation do we need to be having with the patient? Hi, I'm Bill Nudera, board-certified endodontist and author of NuEndo, ReThinking Endodontics. And I'm going to show you how simple it can be for anyone to answer these questions and develop a complete understanding of this case like a pro. Stay tuned. I would like to take a moment before we get into this case and just thank everyone out there who's been using my book. The support I've gotten has just been overwhelming. I got a call from a colleague who plans to use my book as a training manual for all of their doctors. Well, I just think that's great. If you're interested in learning more about my systematic approach to endodontics, I'm going to put a link to the book in the description below. This mandibular second molar has already been determined to be the primary source of this patient's chief complaint. There's no question. I had the patient bite on a cotton swab and everything felt normal until I got to that mandibular second molar and then they bit down, bullseye. No doubt, chief complaint reproduced, pain to bite. Understanding the odds of success or the prognosis of treatment is critical so that all expectations are in line with what's reasonably possible. And the ability to develop this understanding is as simple as asking the right questions in the right order. Based on my systematic approach, the first question, what's the condition of the surrounding bone? So I'm going to take my findings both clinically and radiographically and run them through my initial prognosis screening system. For those of you out there with the book, you should follow along. I encourage it. The prognosis screening system is on page 225. Now, this is a very simple screening method and will ensure that I'm going to be using the right system for the right scenario. The prognosis screening system is going to automatically prompt me to evaluate the condition of that surrounding bone. And based on my radiographic findings, I see that there's an osseous defect there on the distal, and that defect involves the alveolar crest. Now, some of you out there may be saying, well, I didn't see that defect until you pointed it out. But there are other methods that we can use to evaluate the condition of the bone at the level of that alveolar crest, not just two-dimensional radiography. One method being a cone beam scan. By eliminating superimposition of those cortical plates, that vertical defect becomes apparent. CBCT scanning is an extremely valuable tool for me when it comes to developing a prognosis. A cone beam scan will no doubt keep you on the right path. But what if you don't have a cone beam scanner or are not comfortable with reading a scan? Well, the other method that can be used to evaluate the condition of the surrounding bone is probing. The amount of bone loss here would certainly be probable. We're looking at 4.5 millimeters below the level of the alveolar crest and 6.5 millimeters extrapolated from the level of the gingival tissues. If you were to probe around this tooth, you would have gotten conservatively a 6.5 to 7 millimeter isolated probing depth there on the distal. That's significant. We shouldn't always rely solely on our two-dimensional imaging to determine the condition of that surrounding bone. And regardless of which method you choose, either cone beam CT scan or probing, eventually you would have picked up on the fact that there's a crestal bone defect there on the distal. And the screening system would have led you in the right direction. So based on the interpretation of the surrounding bone condition, I'm going to now follow the crestal bone loss system to help develop the overall prognosis for this case. So I'm going to turn to page 238 and continue this process. So now I'm in the crestal bone loss system. Again, that's page 238 for those following along at home. I've already established the fact that we're dealing with a vertical bone defect. And we can see that there's plenty of bone that remains around that root, meaning that the defect isn't wrapping around the root end. So the next question is, what's the status of the pulp? In this case, the tooth was unresponsive to my sensibility testing. Now, what does that mean? Well, it could mean one of two things. Either the pulp is necrotic or the sensibility testing yielded a false negative. I mentioned in a prior video that when a tooth does not respond to thermal testing with no obvious signs of apical pathology, that we should consider the pulp to be inconclusive. But an inconclusive pulp status is only reserved for asymptomatic conditions. This tooth is symptomatic. So with no response to sensibility testing on a symptomatic tooth, the conclusion of pulpal necrosis or even partial pulpal necrosis should be highly considered in this scenario. Once the pulp status is determined, the system is going to want to know if we're dealing with an anterior or a posterior tooth, because it matters. With this being a posterior tooth, we've now got to look at the status of the marginal ridges. Now, sometimes they're not visible, but in this case, they are. When I look at this clinically, I see a fracture on the mesial marginal ridge as well as the distal marginal ridge. And I'll bet that when that restoration is removed, that fracture is going to extend all the way across the floor of that tooth. So we have a clear marginal ridge fracture in this case. Well, that's a problem because that fracture is on the distal marginal ridge in line with that crestal bone defect, our deep probing depth. It's highly likely and most probable that the base of that crestal defect represents the apical extension of that fracture line. So knowing this, does root canal treatment still make sense as the best treatment option for this patient? Because root canal treatment will not be the last treatment for this tooth. Our literature and experience suggests that the long-term prognosis for a tooth with these clinical and radiographic findings is unfavorable. This is the conversation that needs to be had with the patient because many patients believe that once root canal treatment on their tooth is completed, that their problem will be solved definitively. Even under the best starting conditions, root canal treatment isn't 100% successful, let alone a tooth with a necrotic pulp and evidence of a vertical crown fracture. The system suggests that you must consider extraction as a definitive long-term solution for a tooth in this condition, and the systematic process is going to stop. It's now in the hands of the patient and the treating clinician to decide if both parties are still willing to move forward with root canal treatment. Patients who choose to accept root canal treatment under these conditions and the clinicians that provide that treatment must be comfortable with the reality of short-term success. Root canal treatment may relieve some symptoms and stabilize the situation, but it may not relieve all symptoms, and even if it does, for how long? The condition and symptoms of this tooth are secondary signs of a much greater issue, which is primary clinching and grinding, and may be associated with some other uncontrollable variables like stress, or it could be habitual. Root canal treatment does not fix these problems. So as long as these other primary conditions exist, other teeth may begin suffering the same fate. Now, have I done root canals on teeth in this condition? I have, but only after a lengthy conversation that tailors the patient's expectations to what's reasonably possible. My patient opted to have their tooth extracted. Sometimes patients are willing to accept short-term success with the gamble of long-term survival. This one was not. My practice of endodontics follows simple, fundamental decision-making systems. I follow evidence-based systems that help me maintain my consistency, improve my efficiency, and increase my predictability. And I'm sharing those systems with you in my book, NuEndo, ReThinking Endodontics. I've made these systems simple enough so that any dentist, regardless of your experience level, can understand endodontics like an endodontist. So for those of you who have the book, I would love to know how you're using it. Comment below, share your pathways, share your experience. I hope you've enjoyed this video presentation, and I hope to see you on this channel for future presentations. Follow me if you want to get updates on my latest cases and educational videos. I'm Bill Nudera. Thanks for watching.